Good afternoon, everyone. Welcome to our quarterly VCSQI Quality Committee meeting. Thanks all for being here with us. Welcome. We have some special guests this afternoon to share the stage with us. So it's my pleasure and honor to introduce Linda Curry and Maggie Crawley from VCU, who will speak to extubation protocols and how they've been able to decrease their prolonged vent times over at their center. So, there you go, Sherry. So without further ado, we will pass it over to Linda and Maggie. Thank you so much for being here with us today.
Sorry about that. Good morning. Thanks for having Maggie and I today. I really appreciate getting to present to y'all. Is it possible for me to share the one that I have on my desktop? Because I did make some last minute changes. Okay, thank you. All right. Okay. All right, great. Well, I'm Linda Curry, the clinical nurse specialist in the cardiac surgery ICU at VCU, and Maggie Crawley is my partner in crime for all of our cardiac surgery data. And we have been doing a lot of work as of lately on the extubation measure. This first slide I do not need to review with you because you guys know these definitions better than I do. In fact, Maggie's usually the one helping me out with the definitions, so we won't go into that. But just to review briefly, the measure as we know it for extubation for postoperative cardiac surgery patients, being that patients will not be intubated for greater than 24 hours cumulative total during their inpatient stay, and that starts with OR exit time and ends with the patient discharge, and includes the initial hours of intubation plus any reintubation hours. So, you know, this measure has been in place for a while, and unfortunately, in our cardiac surgery ICU, we have not been meeting this metric consistently since the beginning. And it's not that we haven't been trying. I think we just never really had an organized process around that. So it was definitely identified as something that we needed to put some extra work into and see what we could do to improve our measure. Maggie, if you'd like to present the data slides.
Sure. So this shows how we were performing before the project, and you can see that in the first graph is our quarterly ODE ratios, and you can see where we were consistently above the benchmark of 1, and the backdrop is our case volume. So you can see our case volume was increasing as our ODE was increasing too. The second graph is our observed rates, just again shows that we were increasing in numbers, but also in quarter 2 of 2019 is when we were approached by our QHIP team about our points for the QHIP measures for cardiac surgery. So we decided as our quality group that we were going to focus on prolonged intubation. One, because it was something we all could have an impact on, and it didn't really weigh heavily on the surgeon outcomes. So then we decided we also had somebody that needed a Six Sigma project too. So it kind of all fell into place here. Mm-hmm. As going forward, we decided to use a rolling 12-month process to measure our progress. And later on, we'll show you how we did. So, Linda?
All right, thank you, Maggie. Okay, so the importance in the critical care arena to our critical care teams is clearly, you know, we know that having a prolonged intubation is defined as a pulmonary complication, but I think the reason they come to that conclusion is that the longer the patient's intubated, the more complications they're likely to have, incidents of pneumonia and increased length of stay, and readmissions to the ICU after they even go to the floor. And our goal is always to improve the patient's experience all around, and we really want to get the tube out sooner than later to prevent these complications. Previously, you know, like I said, we've been focusing on this and pretty much endless discussions at our QAPI meetings, talking about it in our collaborative practice settings, but it wasn't very organized. Everybody kind of knew what we were supposed to be doing, but there wasn't really a process around it. We had loosely implemented a fast track sign at the patient door, but that really wasn't resulting in any big changes in any kind of consistent way. So as Maggie mentioned, we decided that this was going to be a big formal project. And we started with the process of data drill down. And I had a nurse, a bedside nurse, who had a clinical ladder project that she needed to do. And so we had her start digging into all of the patients that had had prolonged intubations over the previous 2 years, really looking for common themes that may have prevented the patient for extubation as we saw it at the time by looking through provider clinical notes, et cetera. And these were many of the different themes that they came across, things like post-op bleeding with return to the OR, pulmonary complications, worsening cardiogenic shock, presence of balloon pumps or Impellas or ECMOs, neuro changes immediately post-op, or maybe the patient having an open chest or a lot of volume issues. And really the goal with looking at these things was to try to see if we could get beyond our current thinking and decide, do these things really warrant maintaining the ET tube? Were we slow to pull the tube because of these situations? Could we have focused harder on that patient and optimized them more efficiently, and trying to really change our processes? The next step we did was turn it into the formal Six Sigma project. We had Suzanne Geldner, who was our PI person at the time, and she helped us organize a group of stakeholders, which really included a very collaborative process, because we recognized that if we didn't have everybody at the table bought into this, that we weren't going to be able to make any sustained change. So it included our medical director, our unit nurse practitioners, the respiratory therapist, my work partner, who's the nurse manager, the cardiac surgeons, our head cardiac surgery OR nurse, and Maggie. And together, we really took a deep dive into the entire process. One of the first things we did was revisiting the role of respiratory therapy, because as we know, respiratory therapy is integral in managing the vent. It's their wheelhouse, and we really need them on board and present at the bedside. So we took a good look at what their current rounding process was just for managing patients on ventilators in general, much less someone who needs fast track, and tried to break down any barriers to having them present at the bedside, because our current process was that we get a call from the OR when the patient's on the way to the unit, and then we place a call to RT. But what happens if that call doesn't come from the OR and surprise, the patient's here and RT hasn't made it to the bedside yet? How do we work through making sure they're there every single time, so that RT's on board with the team with the plan for that patient's extubation process, and then helping them understand, what does fast track really mean? So our PI person at the time really took a deep dive into the respiratory therapy rounding processes, with the goal of that they should be rounding about every 4 hours. And what we found was there was a great deal of variation in that rounding process, just in general. So a lot of education was done with their team, and not only from what the goals were for that, but for fast track. And then they did a redo look at the data and found that the respiratory therapists were able to shore up their regular rounding processes. And we knew that once we had that in place and squared away, that we would be more likely to have them engaged in being present at the bedside for frequent ventilator changes for the fast track process. The next step was to take a look at our fast track sign. So in 2019, you can see our first version of the fast track sign. We would have this laminated and hanging on the outside of the patient's doors. It would be hung immediately upon arrival to the unit from the operating room. This unit secretary would write in the patient's arrival time, then what 4 hours post-arrival would be, and then 6 hours. We recognize that STS looks at the 6-hour time frame as the official fast track measure, but we also put 4 hours on there, trying to up the ante for our extubation process. But we weren't making any gains with this, and we could not figure out why. So we went back to the table with end users and said, what do you think's going on? How are you interpreting the sign? And what we realized was the end users didn't realize that there was a 24-hour period that we had to get these patients extubated in, and had the patient been really sick and not able to be extubated within 6 hours, they thought that the time frame was up, and they just kind of gave up on the extubation process. So we changed the sign to reflect the full 24-hour time frame, with the patient arrival, the 4-hour goal for fast track, and then the 24-hour end time, because we know not all patients can be extubated in 4 to 6 hours. Some of them are just way too sick and it's not safe. So then we need to work towards getting them extubated before the 24-hour period. Then our providers came up with a really good idea to create an optimization huddle. So we made an additional change to our fast track sign where we added in an 11 o'clock and an 8 a.m. optimization huddle time. So depending on what time the patient comes out of the OR, if they're not extubated within the 4-hour time frame, we would meet at one of those two times, whichever one makes the most sense based on when they came out of the OR, where respiratory therapy, the nurse and the provider who's on will meet up at the bedside and try to figure out what they could do to optimize the patient and get them ready for extubation prior to the 24-hour time frame. And the right side of the screen shows you the different things we would discuss that are on the back of the sign and address. The goal isn't to extubate them at the optimization huddle, but to find ways we can optimize the patient before the 24-hour mark. So we've been using that sign for a while, and it's actually been going really well. Did a lot of education with the entire team, and everyone fully understands all the goal timeframes. The next thing we did was starting a real-time data tracking form. This is a snapshot of the Excel sheet that I keep. This was a little earlier on in the process. I usually have the patient's name and medical record number there for tracking. And you can see we have the date of surgery, the type of surgery they had, and then we would have the providers involved, both the surgeon and the intensivist who monitor the patient and manage the medical care post-surgery. Then whether we were able to get respiratory therapy there for the sterile cockpit, the time they come from the ICU, the time we get them extubated, and then the column in green shows if we were able to extubate them in under 24 hours. The goal to this is to really look at it on a daily basis every morning to make sure that we are on it and that we're really paying attention, having those conversations and staying on top of that in 24-hour mark. So we started doing that. This data is presented to the team in lots of different forms. The next step was to focus on team education. And we started out with our providers, initially getting with all of them in multiple different meetings that we have for our unit, making sure all the surgeons and intensivists and the nurse practitioners who are, steady in our unit, that they're all aware of the process, that they were in 100% agreement, that they understand that every one of them is accountable for focusing on this process. And I educate all new residents that rotate through every 4 weeks on this process so that they're also aware. From a nursing perspective, we did in-person in-services. They also, if they didn't get to an in-person in-service, did recorded Zoom presentation viewings. We include all this content in their orientation classes for new hires, and we give feedback in the form of posting compliance data on the unit. And for unit secretaries and care partners, because they're often the ones helping us hang the signs and put the times on the fast track signs, we did a lot of one-on-one education, email reminders, and if we had float help to the desk for a unit secretary role, we would give them just-in-time education so they would know what to do. For RT, we sent out a recorded presentation, a similar version to what I'm presenting to you today, which they had all their current staff educated on, as well as they use it for onboarding all of new staff. And that way we kind of blanket covered everybody. Defining the roles of this was important, and there's a lot of overlap because no one person can be responsible for any one step. Our unit secretaries, care partners, and nurses are all responsible for making sure that fast track sign gets on the door with the times filled in. The RN, the RT, and providers all need to be present and participate in the sterile cockpit handoff between anesthesia and the ICU team on arrival from the OR. The nurse and the provider work to stabilize the patient, while the RN, RT, and provider work on guiding the weaning process and addressing any pulmonary issues that are arising. Then the RT, nursing, and providers lead optimization huddle if they're not extubated in 4 hours. And then the nurse and RT work to extubate the patient and document the time so that Maggie's able to get the data we need out of the charts. One of the things that we really focused on with the providers was the coding aspect of this, because some patients are not going to extubate in 24 hours. So we know that documentation is imperative so that our ODE ratio is working like it should. So we did some presentations with the data analyst teams and the coding teams during our QAPI meetings. We had pocket cards handed out with the most common DRGs that are in our unit so the providers could focus on the proper things they need to be charting. we pulled in some specific case reviews where we could have done things very differently, or some initial case reviews we came across during the data drill down in the beginning that helped us illustrate what we wanted to see or what we didn't want to see. And we really applied these processes to all of our patient categories. While we were mainly focusing on the isolated cabbage bunch at first, we were still hanging the fast track doors on the rooms, signs on the rooms of all of our postoperative cardiac surgery doors, because we know that valves and cabbage valves and multiple valves and all those other buckets of patients have this same measure that is being watched. So we wanted to try to improve outcomes across the board, even though initially our data daily following was focusing on isolated cabbages. The last step was really focusing on feedback. We have biweekly cardiac surgery ICU collaborative practice meetings, which are interdisciplinary. We review the data there. We also review it in the monthly QAPI meetings. When Maggie comes across patients where we did a really great job with our documentation that helped our ODE on a patient who wasn't able to be extubated in 24 hours, we highlight those cases. And we also do positive reinforcement in the forms of emails. So this is an example of an email that I send out to my nurses, letting them know that they did a great job meeting the extubation measure for that day on that patient, the amount of time they extubated in. Reminding them of what the measure is, just repetition of that measure, and reminding them of how that really benefits their patient and why it's so important. And so we're educating and making them feel good at the same time, moving forward with the process. And this is a slide that Maggie's going to review showing our current data.
So I will have to say Linda's hard work, really, she was the driving force of most of these numbers. And you can see each data point is a historic data point. So we wanted to look at a more longitudinal view of how we were performing. So each data point looks at the previous 12 months. The reason why we really were proud of this is because these numbers are so hard to move, because we had the historical data, and how we performed poorly in the past really reflects in these numbers of the strides we made in reducing our prolonged intubation. So you can see that, and my line is a little bit low, so it should be at 1. So we've been consistently below ODE of 1 since late last year, and we continue to perform at the expected. So when we presented this to our quality group, the hospital is kind of impressed of how we have really moved these numbers, and we are in the process of talking about standardizing this practice among the ICUs to decrease ventilation times in pretty much all patients, or something along the line of decreasing the ventilation times. So I'm very proud of Linda's group and her team of the improvement that we've made.
Thank you, Maggie. One other thing I wanted to throw in here is there was a parallel project that just kind of came up, and incidentally at the same time we were doing this work, where we had a few patients that had to go back to the operating room for postoperative bleeding, and the surgeon really felt that the reason for having to go back to the OR had to do with the amount of agitation and sedation management issues when they woke up. So we dove into those cases and felt pretty secure in saying that a lot of it was tied to the reversal of the anesthesia using the Sagamodex, which is, I guess, been around for a little while now, but historically it was not the reversal agent that existed when I first started in my unit. And really the literature very strongly supports an association between emergence agitation and emergence cough with reversal of anesthesia. And there is documentation specifically in the cardiac surgery population that this increase in intrathoracic pressure can cause trouble for the surgical anastomosis sites inside the patient that they've just made with the cardiac procedure. and that had something to do with it. So I presented the cases to the team and suggested that we use a more thoughtful approach for reversal, because often the anesthesia resident who has brought the patient down from the OR, the last step they really have before going back upstairs is administering Sigamadex and then, leaving. And so what we decided to do was to start stocking the reversal agent in our medication Pyxis dispensing machines, so that we can give the patient a little time to settle in, allow the nurse to get them stabilized, evaluate where they really are in the waking process, because many of them are already starting to wake up, breathing over the vent, doing really well. Then we can evaluate when the best timing is and the need for reversal, get the drug out of the machine, reverse them at that time. And if we're able to do this and not have issues that are sending patients back to the OR or causing so much agitation that we have to then resedate them in order to make them safe, then we can, again, prevent this prolonged intubation time. So the lining up of this incidental side project ended up correlating nicely with our work on the other side of things. So ongoing branch projects, because we're not really done working with this yet. I have a staff nurse currently looking at a subgroup of patients who have been having issues with airway swelling and edema immediately post-arrival, requiring a steroid administration to allow the airway swelling to go down so the tube can actually be removed from the airway. So really looking into that, trying to see what the literature suggests about that and whether there's anything that can be done a little more preemptively to prevent it if possible. Looking at other issues that can cause reoperation, and now most currently, looking at the RN and provider roles with extubation with RT in the event that RT is not immediately available for extubation when the patient is ready, because often they're tied up with other patients. And this is a summary of all those steps that I just went through in our project, and that is all. I'm happy to take any questions that y'all have.
Linda, that sounds great. I'm glad you guys got it going in the right direction. I am just starting right now because we, for some reason, had a big blip in the last year, actually 2 years. So I think the team education and getting, we've taken on some intensivists, and I don't know if they know how important it is to get that 24-hour limit, but I am thankful to hear what you've done, and I'm going to take some of these ideas and bring it on to my people. Thank
Great.
you.
You're welcome. We have an intensivist model as well. I can't remember if I mentioned that or not. And honestly, the intensivists have really been driving factors in this, because once the cardiac surgeons know how important it is, right? They already get all that. They're knee deep in STS stuff. They understand that. And so, it's really the intensivists who are managing everything else, and they work collaboratively with the surgeons once they're there. But once the intensivists understood the importance of the measure and got bought in, they got so into it and really were just excited about doing it. So if you can get them engaged, I think you'll find things start changing really fast.
I hope so. But I think, with COVID and all our meetings going out the window, and suddenly they're just getting reports, whether they look, I don't know. But we did have a big discussion on it this past month. So it's going to become a big project for us.
Great.
And I will say we did not exclude COVID patients like the STS is doing. So this is including COVID.
Okay.
Yep. Yeah, a lot of our meetings honestly kind of went out the window from a broader perspective in the organization, but our collaborative practice meetings with our team twice a month, and our monthly COAPI meetings, I don't think any of them, or very minimal of them, were canceled. And I think that did help a lot making sure, but we also got started on this, I think, right around the time that COVID started, ramping up. And so I think the timing of us getting into this we were very lucky. I'm not going to throw luck out the window there. There's a piece of that.
Well, I think we could hand it back to the group.
Okay,
But
great. Well, if you guys come up with
any other
anything
questions or
else, I'm
comments,
available.
folks?
I'll stop sharing here. There we go.
Well, thank you again, Linda and Maggie, for sharing your experiences, and we'd love to hear more from you as well with regards to kind of how you can keep those rates low, and you touched on reoperation as well. We'd love to hear from you maybe next time about that too.
Great. We'd love to circle back with you. Thank you so much for having us. I really, really appreciate it.
You're very welcome. Thanks again for joining us today. So next up on our agenda, we actually kind of skipped over our agenda slide here, but we have some updates on our quality initiatives, and we'll go into some FAQs as well. Judy had sent in a couple FAQs earlier, so I figure that might be a good way to kind of to jump off and start some discussion here. Judy, would you like to go over these scenarios with us? Oh, Judy doesn't have audio. Okay. Well, Judy, I can read them out. I'll do my best here.
I actually can speak in this because I'm actually the one that initiated it. So I came across a patient that had a creatinine greater than 4 pre-operatively, but wasn't on dialysis pre-operatively. And then this patient ended up going on dialysis after surgery. And I believe his creatinine kind of leveled out. So I didn't know what was considered renal failure. And Judy was very nice enough to send the FAQ, and it did come back that we needed to code there is a renal failure with and then check yes to dialysis. I haven't been doing that. Judy said that she hadn't been doing that. I didn't know if any other people were not doing that. What are your thoughts?
What was the question, Maggie? What
so if they had a creatinine greater than 4 preoperative, so they do meet the criteria for renal failure. They will be excluded on the back end for the DCRI.
Right.
But in the training manual, they still want us to code dialysis, yes. I mean, renal failure, yes, and dialysis, yes. Even though
I've been doing that. I've been going strictly by what they say, but my guys are pretty proactive, and they a lot of times will dialyze them pre-op, so that makes them fall out also, because they have a history of dialysis then.
Right.
But yeah, I got nailed on this once or twice, and I brought it to their attention, and so they're a little bit they get renal involved early, and a lot of times they will dialyze them if they can't get that.
So how is that affecting running reports? If you run, if it's a complication, I have to say yes of a complication, then it's a yes. But on the back end for the STS, it's not included. So you're just still reporting out that the patient had renal failure, even though they were in failure before. Okay.
Yep.
There's a note in the chat from Judy. She thought it specifically says a new requirement of dialysis.
Right, but it's also if there is a 0.5 increase, if you start over 4 and there's a 0.5 increase in serum creatinine, it's also renal failure. Even if they don't have dialysis. Like if you have a 4.2 and it goes to a 4.8, it's renal failure.
I think me and Judy had a little issue with that too, because we feel like the 0.5 rise was more of creatinine that straddles at 4.0. So it'd be 3.5 to 3.9 that would really affect the 0.5 rise.
Well, if it's under 3, it's not renal failure.
Well, if it goes from 3.9 to
2, yeah.
4.
Yeah, then it is. Yeah.
But if it's above 4, so like just say if it's 4.1 and it rises 0.5, so it'd be 4.6. That's I mean.
Yeah, I would still. There's a question in the training manual, and it pretty much point blank says, yes, that is renal failure.
And then when does the 3 times the baseline?
For everything that's under
4?
Under 4, like if it's 1 and it goes to 3.2, it's renal failure. But if it's, you know, if it doesn't go over 4, like say you started at 1.5 and you went to just 3.9, that's not 3.5 times, but I mean, anything, if you start with a low creatinine and it multiplies 3 times and it's still under 4, it is renal failure. If it goes over 4, it's also renal failure. But, you know, you get some of these little old ladies who drink, and then, you know, for whatever reason, their creatinine goes from 0.5 to 1.6, you got renal failure.
Yeah, I think we were coding that if they were in renal failure before, we did not say they were in renal failure post-op because it's not technically a complication. But in this case,
I only did that if they were being dialyzed pre-op. If they weren't being dialyzed pre-op and they were in renal failure, it's still a complication is how I've been coding it.
Right. Yeah, because my example was his pre-op creatinine was greater than 4, but not on dialysis. So the post-op need for new dialysis, I should have been coding as renal failure.
Okay, I think I'm on now.
Yay!
No, I don't know. You might not say that. I've got I can't turn my volume up on my. Hold on. Okay, how am I now? Yeah, I just never want to see any more renal failure than I had to. Now, the good thing is I think we haven't underreported. If it's just Maggie and I that have done this, because everybody else I talked to, they have been coding it as post-op post-op renal failure. But in the big scheme of things, as far as what you look at for our data and everything, STS takes those patients out, right? That's what she said. Like they'll take out anybody with a creatinine of 4 or greater. They're going to be removed from the risk model. Like they don't even get a risk score. If you go look at the risk scores for the blank. Okay. So it's not like we've missed any, you know, I'm like, and if STS isn't going to look at them, I don't want to look at them. And I did just say to Melinda, I'm like, you know, this makes reporting. So Eddie, I would say for you, when you report our renal failure in the AKI group, you have to also exclude all the patients with a creatinine of 4 or greater, because they're not technically considered. Now, I will go, I'm actually thinking I might go back, because it's not that many of the patients, just go back to 2019 and code it. But I pushed Melinda pretty hard on it. She's going to talk to Carol, but she'll clarify it in the training manual. And the reason I picked up on it is exactly what Tracy said. It's because she said if you go from 4.1 to 4.6, that's an increase of 0.5, so that would actually count as renal failure. And I'm like, well, you're not going to, how can they be in renal failure? Because they already were in, you're saying they're already in renal failure by definition, but whatever. I will do what I'm supposed to do. But I have not heretofore been doing it, but I will do it going forward. I might go back to 2019 because it's not that, or 17.
I'm sure it's not very many patients. You know, I wouldn't think.
It's not many. It's not. But like, why, guys? I mean, STS isn't going to count them as AKI. Why should I? Because they said so. I get that. It's like mom, because mom said so. I get that. But like,
It's exactly why, because mom said so.
I mean, basically, right? Like, I mean, to me, it just blows my mind that if STS is not going to count it, then I'm going to count it locally. It just makes running reports more difficult. I did talk to my one of my nephrologists. I'm like, does a creatinine 4 mean you've got end-stage renal disease? And he's like, yeah, you could be a 20-year-old, 100-kg guy and a 4 for creatinine because you've got all that muscle. Creatinine is just in your muscle. It's not like what your kidneys are doing. It's just what you got in your muscle. So I'm like, okay. So I don't even know why STS excludes them, but I'm glad they do. Yeah, Vicky says, like, if somebody has a creatinine that high, why won't they do dialysis? And I have to tell you, I mean, it's AEIORU, acidosis, intoxication, like drug, electrolyte, volume overload. You have to have a reason, and creatinine is not a reason to dialyze somebody in over here. But it's a good question.
Yeah, I think our renal group is very hesitant to start dialysis and hoping they'll have their own recovery of function without it.
Good. Vicki, you haven't been doing this either. Yay. Because I do think Melinda needs to clarify this in the training manual. To me, it was not clear, but I'm a very concrete thinker. It just makes reporting worse, but I will do what she says.
Awesome. Well, thanks, Judy. Thanks, Maggie. I will move to the second question now. And this is along the similar lines, right?
Yeah, that was me. That was just a second piece of, because it's not just dialysis. It's not just dialysis that you say yes to it. Is if you go from 4.1 to 4.6, because that's exactly what's in the training manual, which made me ask the question, like, oh. But she's going to try to do some clarification, and I thought maybe they could do it as a survey monkey or a survey question on one of the calls, because I don't think we're the only 3 people in the country doing this. Eddie, do you automatically exclude people with a creatinine of 4 when you do the AKI reports?
I believe so, because I think they don't have a predicted risk score. So
right, that's true.
Out.
Well, I wonder what STS does with it.
They throw them in that drawer that everybody has that just is full of random stuff. Well, while we're on the open forum here, are there other questions, comments you all would like to share?
I got a response to my inadvertent PCI question. I had a patient that went to surgery and they found that they could not do one of the vessels. It was just unable to do it. So they decided, they had a conference in the OR before they came out and decided they were going to do a PCI before she left. They took her back to do the PCI on the vessel they could not bypass, and they found that one of the grafts had already occluded. And so they also did a PCI on that graft, even though she had no chest pain, no heart failure, no symptoms at all. So if she hadn't already scheduled for, the PCI, they never would have found it. Well, they came back and told me that, yes, it would, to code reintervention for that graft PCI. So.
Great, thanks, Tracy. Other questions, comments to share?
I can add on to Tracy's FAQ. A while ago, I think it was maybe a year and a half ago, I had a patient that went back to the cath lab. They were intending on doing, it was not planned, but they intended on shooting the left side of the heart, and they found one of the grafts were down, but they couldn't stent it, even though they wanted to. And I still had to code that it was a reintervention, but that was on the old form.
Really? I thought
Because-
if you couldn't do anything, you didn't count it. If they didn't do anything, you don't count it.
They said that the intent was there to stent it, but since they were unable, because I can't remember the circumstances, it was something other than getting the guide wire through there. She made me code it anyway, but just not do, I think on the blast form, we had to put whether it was a graft, or a native vessel or a graft. We don't have that anymore. But before that, I just had to leave that blank.
Huh. They did try to stent it?
Yes,
Oh, okay, yeah. If you put a wire in, then it's considered a stent.
but they
Stenting,
couldn't.
so-
They couldn't pass the wire. I mean, they
But
couldn't
then
pass.
they put the wire in just to try.
Yeah,
Then I think then I can see why. I think if they just at least try, even to push the wire through, then it counts. Well, Judy gave me good news the other day. She said we are not changing
What?
versions. And for people that aren't on the call, that was news to me. So thank you, Judy, for listening.
You're welcome. Yeah, you're welcome. It was a little cryptic, like there's a lot going on at STS, or I don't know exactly what Carol was saying, but they like the version as they have now. I mean, I hope that I'm pushing that to have IQVIA take out some of those crazy warnings, like, we get so many of those warnings that just aren't helpful. And that to try to use, like, they've got enough data now that they can get a good sense of what are normal values and what are true
Right.
outliers. But, 120 hours in the ICU with the way beds are going, like, that's not that, or whatever hours it is, you know what I mean? Like, that's not a helpful warning. And guess what? You're getting heart surgery. Your PA pressure is going to be high, probably. They just pick normal numbers. She said the surgeons pick the normal numbers. So she's going to take that back to them and see if she can't get a good sense of what what our patients really, really look like, and then get different outliers to get the warnings for that might be more meaningful. But certainly the ICU hours have to be changed, and the pump times, and I think.
Yeah, I mean, I just ignore them.
I know, but there's always that one little thing in there where somebody weighed 1,000 kilograms. You know what I mean? Like, I always get like one little thing I really should pay attention to, and it's garbled up in all this extra stuff.
That is true.
Well, they said there'll be some continuity. I think they've always done a version change every 3 years, so it'd be nice to have a little bit more stability there.
But the problem is the industry changes so quickly. It's always a little bit behind with what we're doing. But hopefully they won't. Well, I mean, I shouldn't say that. Hopefully we won't wait, but I'm glad they're not doing it.
I was kind of hoping they'd get a new one and have less thoracic or less aortic fields again.
Keep dreaming.
I know. Well, my guys don't even look at it. They don't fill out anything. It's pretty much unknown. I guess we don't do enough for them to be We got other problems. That's all. We got bigger problems than that.
Vicky says in the chat, she says, in ARMIS, you can hide warnings that are superfluous. Well, we're just about quarter till the hour here. I wanted to pass it back to Sherry for some updates from our VCSQI committees and work groups.
Sounds good. Good afternoon. Well, good evening, everyone. Hope all is well. So during our quarterly meeting this evening, we will not be giving updates on our quality improvement initiatives because we wanted to focus specifically on the cardiogenic shock initiative. So just a couple of updates on some projects that we're working on. The first up is the Perfect Care and VCSQI network. This is a collaborative that we're working with Atrium Health on developing in a sense to expand the services, best practices, sharing data across state lines with North Carolina. Perfect Care is starting a collaborative within their state. So far, we have Wake Med that has participated in a few other healthcare organizations as well. So right now we've been meeting, we're going to meet every 6 months. We are currently sharing summary level data, which means we're showing an average of what the VCSQI metrics are for specific categories, and we're comparing it against Perfect Care's summarized data. We're looking for opportunities to look into financial aspects of it to see best practices as well. Some opportunities that we can use to share best practices includes ERAS, for example. As we know, Wake Med has recently wrote a paper, actually it was about a year ago or maybe 2, as they started some ERAS protocols or initiatives that they embodied into their healthcare organization and had favorable outcomes. So this is the opportunity where we can learn from each other across state lines and see what else develops. Any questions or concerns about the Perfect Care Collaborative?
Is it more than one hospital, or is it just?
Yeah,
No,
it's more than one hospital. You are correct. Lobdell is in the process of recruiting additional members. If I'm not mistaken, I believe he has about 4 hospitals in his collaborative, but he is working to recruit more.
And Judy, the goal would also be to kind of share across other collaboratives, like with Maryland, with Northern New England, other organizations like that.
that's awesome. I mean, like even that little Michigan thing, that link in Michigan, like when you do your harvest, you can go put your harvest files through that Michigan thing, and it finds things that like IQVIA and ARMIS don't find for you. I mean, I feel like I've learned a lot from those other state people too.
Yes, it is a great initiative. And if you're interested in joining this fabulous group of thought leaders, please let me know. I'll be happy to sign you up. All right. Any other questions about the Perfect Care Collaborative? Okay, next up, we have AKI. I must say our AKI work group is phenomenal. We have currently 3 champions for the work group: Mike Brown, who's a perfusionist at Mary Washington; Chris Seisma from Winchester, who is in quality and outcomes, has a background in cardiology as well as surgery. And actually this slide is a little bit outdated. Dr. Tiemann, actually who's on the line with us now, is the champion for the surgical perspective with this initiative. Throughout this project, we are working to develop standards of care or best practices and recommendations to mitigate AKI. We have received a copy of STS's draft guidelines, and the committee or the work group within itself has developed their own standardized recommendations prior to receiving that draft protocol from the STS. As it stands right now, we are combining the two protocols together to create a more robust recommendation. We are calling upon specialists to help us to define best practices within this protocol, such as nephrologists. We had a wonderful nephrologist from UVA who participated and gave us some recommendations as it relates to creatinine for once. When should a nephrologist be contacted should a patient's creatinine plateau? So those are some opportunities or some efforts we have been making in trying to figure out the best practice and recommendations that we can distribute across our organization. Dr. Tiemann or Judy, do you have anything to add? These are also very active members of the AKI work group.
I defer to Dr. Tiemann, he's our expert.
And he may be on a call. So we'll proceed and he can chime in at any time. All right, so up next to the fold, we have our healthcare disparities work group. This is a fairly new work group that we have put together this year. The champions of this work group, we have David Wyatt from Carillion, Ramesh Singh, and David Rake, can never say his name, from Inova, who's participating as leaders or championing this work group. They all have extensive involvement as it relates to healthcare disparities within their organization or a part of national organizations as well. We have a small but mighty work group developed, and we are currently looking at data comparing VCSQI demographics data against the census data within the states. Just doing some comparisons as it relates to, are we delivering the best or delivering equitable care in the communities in which we serve? We have found some phenomenal and very compelling information. And at this point, we're looking to figure out the best approach to tackle this because there's many facets. There's a structural facet as it relates to the leadership within organizations. There's a community aspect as it relates to serving the population for which your hospital serves. And there's also a patient education aspect as well. So this is a new, very phenomenal work group that I'm pretty sure you will be hearing more about. And if you're interested in participating and helping us to prepare guidelines, please let us know. Hi, a late question for the AKI. We in Centera use Divert system to minimize contrast use. Any experience on this tool? So this question is posed to everyone. Does anyone use Divert system to minimize contrast use? Okay, I will take that as a no. I will find that answer out for you within the AKI work group, and I will pose it out to a couple other members within VCSQI to find that answer for you. And once I have it, I'll shoot you an email. Okay, any questions about anything I've mentioned so far? Okay, up next, we have our perfusion work group. So well, if you don't know already, there's a meeting after this meeting, actually, that's for the perfusion work group. This work group is also very dynamic. We are looking for perfusion representatives from each institution, and I believe we've been successful in accomplishing this. However, there's a few more that we want to get representation from. The champion for this work group is Eve Dallas from UVA, who I believe is on the line with us as well. And I'll have her chime in to add any additional aspects that she may wants to share. The goal for this project is to share strategies and experiences to garner best practices and create standards of care for perfusionists across Virginia. Within this subgroup, within this group, we have 3 different subgroups that are focusing on specific projects. The first is the AKI post-CAB, and this kind of folds into the VCSQI AKI work group as well. We're also working on goal direct perfusion and EMR integration. So we'll have additional updates at about 4:30 when that meeting takes place. Eve, if you're still online, would you like to add anything?
Thank you, Sherry. That was terrific summarization. Yeah, at the meeting at 4:30, anybody's welcome to attend if they choose to, if they'd like to. We are going to have a report from Mike. We are glad to have allowed him or asked him to fold his work from the perfusion group into the main body AKI group. Otherwise, he's too much. So our committee is actually folded in. And we're also going to talk with someone about a preliminary quality report with perfusion specific data as generated through Epic. And so that's an exciting opportunity that we're going to talk about then as well. Thank you, Sherry. Appreciate the opportunity to give an update.
Thank you as always, Eve. So last but not least, we have our shock initiative. If you have not already registered to attend this event that starts at 5:30, please, it's not too late. You can still register or you can still join us via the same link that you're using now to attend this meeting. So the champions for this work group, we have Benim Tarani from Inova, and we are also partnering with VHAC. And the leader of that organization that is helping us is from Kerwillian, Dr. Peter O'Brien. The project goals is to assess current shock management strategies. Earlier this year, we sent out a survey to 38 PCI centers to give us an overview of what are their current shock management strategies, so we can just get a better understanding of what is taking place. As we go forward, we would like to develop shock management protocol and potentially develop a shock management registry. So to learn more about this project, please attend our 5:30 meeting. And again, you can register. The link to attend is in your chat, or the link to register is in your chat. And also you can attend just by joining back into this Zoom meeting, the same address at 5:30. And that is it for my updates.
Louder before.
Yeah. Any questions or comments? Okay, Eddie, I'll toss it back to you for a closing.
Thank you so much, Sherry, and thanks to everybody for joining our monthly and quarterly quality committee meeting this afternoon. Again, we hope you can join us for perfusion and for our shock focus this evening. And if there's nothing else, please feel free to email our group. We can take things offline before our next meeting, which is scheduled for December in terms of our quarterly meeting. And yeah, thanks again, everybody, for being with us today.
Thanks, Eddie.
Thanks. See you in a bit.
Sounds good.